So I think we're learning more and more about the mutational landscape in MDS and its impact on transplantation. I think it's well recognised that those patients who have P53 mutation are in a particularly poor prognostic group if they have a biallelic hit, so a double hit of their P53. What's also apparent is those patients with a monoallelic P53 abnormality actually are in a better prognostic group than we perhaps realised before, and that's really data that's emerged from the work of Elsa Barnard and Ellie Papo-Manuel. And I think that in general, people are using those data to help guide decisions about who should proceed to transplant or to take patients to transplant within the context of clinical trial, for example. What we are still yet to understand, knowing that those patients who have the worst mutational profiles, including having double hit P53 mutation or RUNX1, for example, that we don't really know what the impact of post-transplant therapies could be in terms of trying to improve the outcomes, which is traditionally a very dismal outlook, with less than 20% overall survival long-term for patients with very high-risk complex monosomal karyotype, for example, MDS or AML. And so I think we've got much to learn. And so whereas perhaps we might say that certainly there is significant debate about which patients with the most adverse risk profile should go to transplant, you could, on the other hand, say that, well, in terms of the post-transplant strategies that we could use to try and boost the effect of the transplant and graft versus leukemia effect by using, for example, maintenance therapy such as Azacitidine, and that's really being evaluated in the current MDS clinical trial, or donor lymphocyte infusion, for example. How could that modify that poor outcome that we see in that particularly high-risk category of patients? So I think there's much still to be learned. I think it's still quite clear that those patients who have a number of mutations with MDS are more likely to do worse. There are certain mutations that perhaps predict a slightly better outcome, for example, mutations in SF3B1. But what will be interesting for us all to apply will be the IPSS-M, which has now been presented, and we will be starting to use that score to really try and understand MDS patients across the board better. So this will predominantly change those patients in the lower to intermediate risk groups, where some of those patients may have a higher risk mutational profile. So what does that actually mean in terms of decision making around transplant? And I think that's an area that we need to focus on in clinical trials going forwards.